Good morning. Why don't we get started? My name is Matt Hutter. I'm a general laparoscopic and bariatric surgeon from the Massachusetts General Hospital in Boston, and we're here today for the SAGES response to healthcare reform. We have a great bunch of speakers this morning, and we'll have plenty of time at the end for discussions and questions. So please tweet, text, submit any questions online, and we'll be sure to get to them as well. And there's always the opportunity just to come to the microphones at the end. I'm the co-chair, along with Dr. Eli Lerner. Eli will be kicking us off this morning and presenting some of the speakers. Dr. Lerner is also a laparoscopic surgeon. He is the past chair of the legislative committee for SAGES, and he's the faculty of University of Florida. He is currently the representative to the AMA for SAGES. Dr. Lerner.
Can we get my first slide up, please? My function here today was to help put this panel together. I had several slides that I wanted to show you the depth of the problem that we're facing so that as the discussions ensued, you'd have some sort of a quick memory device to return to. The problem that we're facing these days is that the cost of medical care has escalated so much that absolutely reform is necessary. The federal government has answered that by designing a legislation called the Patient Protective and Accountable Care Act, or PPACA. There's my slide. The first one here shows the growth of Medicare since 1968 to 2008, and you can see that these costs are almost on they're on a skyrocketing course to go off of the chart. This is the bill that the government came up with, the Patient Protective and Affordable Care Act, and this is really where the trouble began because it's not a simple bill and there are many questions associated with it. As a matter of fact, this is what, if you organize it and take out the committees and this is just new bureaucracies that are going to be involved with this program, this is what it looks like. After the administration got hold of it, they changed it and made it a little bit more complicated. And so now we're stuck with trying to swim through this sea of committees and bureaucracies and so on and so forth, trying to get answers to how health care should go. Now, the federal government is not the only ones who are involved with these exchange mazes. RomneyCare in the state of Massachusetts also is guilty of the same problem. And as you can see from this slide, it's a little bit less complex, but still very difficult to follow. What has this done in terms of private insurance? Well, we're not sure, but we think that what's going to happen is that even though your insurance programs are supposed to be untouched, we can't see how a private insurance company is going to be able to carry on in the environment that's coming forward, and we expect that a lot of these programs will simply close down and people will have to go towards a single party payer over the long run. So with those in mind, I would like to call my co-chair up to make the first introduction.
Dr. Frank Opelka will be our first speaker this morning. Dr. Opelka is a colorectal surgeon, and he's currently the Vice Chair of Clinical Affairs and CEO of the Louisiana State University Healthcare Network. He's also the Associate Medical Director for Washington, D.C. for the American College of Surgeons, and is somewhat responsible for all things related to quality there and doing a great job of it. He founded the American College of Surgeons Surgical Quality Alliance, which is a group of 22 surgical subspecialties who work together closely in all matters related to quality, policy, access, and providing efficient care. So Dr. Opelka will be speaking this morning about quality issues in the accountable care organizations. Thank you very much, Dr. Opelka.
Eli and Matt, thank you very much. It's really my pleasure to be here. And I'm going to go through this, hopefully rather quickly, because I think getting into the Q&A is to me more important, which we'll have once all our panelists are finished with their presentations. Quality and ACOs are kind of an alternative payment system, and if we were to just sit down and pick one of those apart, I mean, this entire meeting is all about quality. It would take us all day to talk about it. So this will be a very high-level view at the national policy level of where quality is going and a little bit about how that interfaces with alternative payment systems. So if we looked at that slide that was just presented about all the different new agencies and committees and groups and efforts, there are two of those on this list, the National Priorities Partnership and the National Measures Application Partnership. That to note, and the National Priorities Partnership says what are the quality issues we need to address and reports that to the Secretary. Those quality issues then get measured, get put into a measurement process, and then go to a Measures Application Partnership which decides which measures will be used for payment and public reporting. So those are already two spin-offs that are alive and breathing and have got significant action moving forward from the Affordable Care Act. I guess the big message of all this is that we've left the status quo. We will be measured from now until the end of time in how we deliver health care. The demand that's out there, buyers want to price quality assurance, delivery systems need to manage value, so data are the coin of the realm. Patients want to know more where to get care. They know that we know an awful lot about where to get care, and they're wondering how can they find out what we know when we decide to get our care? How do they know that same bit of information? Quality is a circle. It's a continuous, virtuous, improving circle. This has been well laid out and put together in a collaboration from the Brookings Institute and with ARC. It begins at the 12 o'clock position where we set priorities. It goes through measure development. It has measure endorsement. It has measure implementation. We then study the measures, and we're learning things like these measures of structure, whether you're licensed or processed, whether you gave the right antibiotic at the right time, are not as critical as outcome measures. No surprise to surgeons, but how do we do that across all of healthcare? And then we learn about how we actually have drivers that actually drive and improve quality. So this is the framework under which all these quality metrics are built. You can't see the detail in here, but in each one of these boxes, there are different agencies or collaboratives, whether it's private health plans or the boards or whomever, that are all involved in this national effort. How it affects you, the individual physician, comes down to three basic points of contact as a surgeon. Your hospital credentials is now quality-based with this ongoing physician performance. Specialty boards have gotten involved in this in Maintenance of Certification Part 4 as a quality initiative. And then the health plans through their accountability, whether it's performance-based payment, performance-based contracting, or value-based modifiers. There's an array of activity that now links all this together. That framework, under a little closer microscope, quality has measures of structure, process, outcomes. These are the Donabedian measure sets. There are measures that are involved with safety, a key issue from industry that wants to know that we've got safe systems. There's a real effort to look at resource use and appropriateness of care. If we just looked at the amount of radiation we overexpose patients to, it is phenomenal and striking, and we now know that we're over-CTing patients to the point of we're increasing the risk of cancer. So it's those kinds of safety issues and resource issues and the cost issues related to them that are driving all of this. And then finally, the patient experience of care. In particular interest is an emerging field of patient-reported outcomes, where we're learning there's an awful lot of clinical association with our sense of what good outcomes are and what patients believe they are. They're not as far apart as one might think. When we merge things like the Medicare administrative database with the American College of Surgeons National Surgery Quality Improvement Program to look at this and look at variation and look at those things we might measure. These are the results of a recent exercise with CMS and the college of looking at colorectal resections in the elderly, 65 and over, And the performance measures of interest, mortality, superficial surgical site infections, deep SSI, sepsis, septic shock, reoperation, readmissions, and more. When we took those results from 400 plus hospitals in NSQIP and overlaid them on the rest of the Medicare fee schedule, it amounts to roughly $2.9 billion in surgical complications. Now, how much of that's preventable? If 5% of that is preventable, that's a big number in just one operation. So this is why the big effort's out there. We don't have any new money to put in healthcare to pay for these new costs. We've got to do something about improving the system to figure out how we're going to fund the future. And we do that through improving the quality and the value of what we're purchasing. So here's a clinical example of how this works. I don't think there's any better solution than using clinical data. We're stuck with administrative data because that's what's out there, but the big drive from the college and from many specialty societies now is how do we move from where we are in performance measurement to where we should be, and what are the barriers and how do we overcome those barriers? These are the best results there are in surgery, and I don't know that we'll get better except to mine these better than we currently do. So here's the big effort. CMS gets that. Center of Disease gets that. ARC gets that. It's just what are the barriers in the way to get there. Now, linking this to payment goes all the way back to Hammurabi. It's nothing new. They're a little cruel in their form of punishment there. There are three classes of citizens. On the far right, you've got slaves, the wardums. Then you've got the middle class, the mushkanum. And then you've got the wealthy, the uellum. And you can see the pricing differed, but you can also see unsuccessful operations cost the surgeon loss of hand if it was to a wealthy person, or loss of a slave, or the price of a slave. So accountable care is not new. We're looking at alternative payment systems that link to quality, and here's a whole array of them, and you've all heard about ACOs as a big component of that. For surgery, these 11 different payment models, the one to probably think about in terms of ACOs is how do we bundle surgical care, and how do we put that bundle either disparate from an ACO or within an ACO and contribute to the accountable care of a population. ACO is payment at a population-based success level or failure level. All of this is actually now prescribed in the Measure Application Partnership. There are clinical measures for all physicians. There are hospital measures for all hospitals, and now that we have so many physicians who are hired by hospitals, those physicians won't be measured under the clinician plan, they'll be measured under the hospital plan. And then there's a whole other array that doesn't involve surgery so much, but it's post-acute care and long-term care. If you look beneath these three, clinical, hospital, and the PAC, LTC, you'll see the different payment plans that are out there. The PQRS, the EHR incentive plan, meaningful use, inpatient quality reporting, cancer hospital reporting, and so on. These different programs are actually now loading up today with performance measures that will begin measurement in 2013 and will impact payment in 2014. And it'll look like those colorectal measure sets that I showed you that we mapped to the CMS measures. So there will be an array of these. There's over 400 measures in hospitals. There's over 300 measures for the clinician groups. There isn't going to be an area of medicine that won't fall into this in some way, shape, or form and be linked to payment. And this is almost regardless of whether you repeal the Affordable Care Act or not. This has got so much momentum from all sectors that it's probably not going to stop. So how do we put all this together in bundling? Here are the 10 commandments. They're not really set in stone. They're my work that we're doing now with groups inside the college. We're thinking about how do we give a guidebook to bundling. Create a bundle that's either condition-specific for cancer or procedure-specific for colectomy. Or should it be combined, a colectomy for cancer bundle? Bundle the surgeon in the hospital first, keep it small so that you can get your arms around it before you expand the bundle to, say, anesthesia, lab, radiology, and so on. Bundles need a window. They need a beginning and an end. Is it 3 days before surgery? Is it 30 days before surgery? Is it 90 days after surgery, 6 months, or a year? Procedure-specific bundles have a short window. Condition-specific bundles can have a very long window. For example, a cancer bundle might have 18 months. The bundle should have balanced representation in its governance, and don't assume insurance risk. Don't cover the flu in your bundle. Cover the complications related to the procedure or the condition. Use evidence for establishing what's warranted and unwarranted, so use a guideline approach to your bundle development. You have to have inclusion and exclusion criteria. We're not going to include renal failure. We're not going to include something else, but we will include pneumonia. And then within the same, you have to have data dashboards that analyze all of this, and you must establish clear cash flows for everyone in the bundle. If not, it'll fall apart because of lack of trust. The entire quality enterprise, pay for performance, linked together, really is all driving toward improvement and getting the best we can for what we're expending. To improve, it's a whole new science for us. As a team sport, the team has to have a will. The team has to have ideas that are shared across a country. You have to have the ability to execute, and you need to make sure you don't overreach. Start small with rapid testing and measurement. This entire improvement science is the PDSA or PDCA cycle. You'll find it on IHI's website. Other areas in surgery are starting to delve into how do we drive improvement in surgery. The National Surgery Quality Improvement Program is totally a learning network, and what that affords you really is the answer for how do you drive improvement science. There are many different tools to look at improvement. This is one, the fishbone diagram, that lines up all the different drivers that touch a patient across a continuum, and when you get inside these improvement cycles, you're going to need to lead them. We've been living in the silos of our practice, but we can't drive improvement across an entire delivery system within the silo. So we've actually got to appreciate and embrace the entire fishbone and provide the leadership that surgeons are trained to give in this environment. So in conclusion, the physician in the 21st century who's looking at all these, it's an accountable system, no matter how you look at it, whether it's bundled, a bigger picture of the ACO, the individual procedure you do, but you got to be part of a learning system. My caution is accept risk in the delivery system, but not in the insurance system. You're going to demand clinical integration to get that done, and you need data. It's the whole enchilada is in the data. And we don't even know what information we're going to need to get the job done. There's a lot of uncertainty about where the real answers are. It's only through clinical expertise that we'll get there. We've had it good for a while. We're all comfortable. We got the penguin on the spit. But you've got to take this up another notch and really be involved, or else you suffer the consequences. And I know a lot of people feel like this, but the opportunity is there. The framework is actually starting to emerge, and it's all about measurement. Thank you.